It is January 27th, 2026. Our patient travels here from Melbourne, Florida. And he has, I'm going to inject, Berndes. He has 2 bad discs causing pain and pinched nerves. So he's suffering from right leg symptoms and discogenic back pain. 2 problems. We're going to go in there and repair both discs today. L3-4, L4-5. So, if you have questions, feel free to ask. I think I might go a little higher on my entry. Blood pressure's good. Come on, Jordan. Henry, let's show the audience how damaged discs cause so much back pain. It's #1 cause of back pain. Chronic back pain in the world. Shot?
Disc injuries start with an annular tear, damaged nucleus. Pulposus herniates into the annular tear. The herniation triggers an inflammatory response within the annular tear. The inflamed annular tear generates pain signals. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922.
Right, welcome back. And you can see from our video that disc injuries cause back pain. And the way they do it is through a process called inflammation. Inflammation is your body's defense system, usually used to attack foreign invaders, but your body sees the herniation as a foreign invader. Therefore, it attacks it. Shot? And it's that inflammatory process that is responsible for the back pain that people feel. It's extremely localized back pain, meaning that the patient knows exactly where it's coming from. For many years, we were taught that back pain is non-specific. He's doing all right? Yep. Non-specific means there's no specific cause. That's what I was brought up to believe in my training as a doctor, as a neurosurgeon. However, when I started practicing with patients, I realized back pain did have causes. It was just that nobody knew what it was. And believe it or not, the people that know the most at the time, 20 years ago, were the chiropractors. Chiropractors had a pretty good idea of things that caused back pain. Discs, facets, SI joint, piriformis. So I learned a lot from the chiropractors, lateral. And what they taught me was that, #1, back pain had a source. And of course, if you listen to therapists and chiropractors, they'll all tell you that the treatment that is the best for the patient is, of course, therapy, but that's not the case. Do you think we're close enough to do a discogram? We don't have to if he's too sleepy.
How you doing, my friend? You okay?
Our patient is awake. He is sedated. We call it conscious sedation. It's where he has basically a IV that's giving him medicine. All right, we're going to...
Open your eyes.
Shot. We're going to proceed, Dr. B. Shot. I think we're good. Look at that. That was pretty cool. You guys got a little cine right there where you saw the dye leak out the tear and go up around the nerve. That's the nerve root up there. Show us where the nerve root is. Yes, that dye is wrapping around the nerve root. That is the, let's see, 543 L3 nerve root on the right. And that gap right above the arrow, that white area right there, is the actual nerve root. The nerve root itself doesn't get dye in it. It's the space around the nerve root that does. Shot? All right, so there's at our L4-5. You can see the guide wire in the disc. And we're going to bring our dilator down. This is the dilator. It's going to spread the tissues inside. Now, we're not cutting anything in this patient's body. We cut nothing except his skin. So the skin is on the surface, but we're not cutting anything inside. And that's important because other types of spine surgery, like laminectomy, discectomy, fusion, artificial disc, those types of invasive surgery, spinal cord stimulators, they all cut. And what those doctors are cutting is the normal things around your spine or in your spine, like your ligaments, or your facets, or your lamina, your spinous process. We don't want to cut those structures away because, well, they're there for a reason. They're there to stabilize your spine. And once you start removing them, well, that's what causes adjacent problems, for example, like adjacent segment disease, and it causes scar tissue. Berndes? So we don't want adjacent segment disease, and we don't want scar tissue. We don't want to remove the natural normal structures that are doing their job in your spine, holding it together, allowing movement. So the Deuk laser disc repair is a procedure where we're able to go in without cutting anything inside. We go straight to the damaged disc shot, like we're doing right now, and we're going to get into that damaged disc and repair it. Any questions?
At this moment, no current questions.
Shot? All right. This is not an easy one, but we are in. We're starting with the L4-5. We're going to do the L3-4 next. All right, Henry, let's show the audience what we're actually doing with the laser and the endoscope.
Copy that.
Shot?
Disc injuries are a common cause of chronic back pain. The inflamed annular tear causes back pain. A 1/4-inch sized skin incision is made. A small tube is inserted with no damage to the bones or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own after the procedure, which can take up to 12 months. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922.
And welcome back. And you can see from our video, we go inside the disc with the tube. That is the tear. You're looking at the annular tear right there. The blue material is the herniated disc. The white stuff is the annular tear. And we have a special pink stuff right there. That is the inflammatory tissue we're here to remove. That's the source of back pain right there. I'm the one who discovered that over 20 years ago now at Deuk Spine Institute, that it is inflammatory tissue within the back of the disc called the posterior annular tear that is the cause of back pain, neck pain, thoracic pain when it comes from a disc injury. Okay? Not all back pain comes from a disc injury, but about 85% of back pain comes from a disc injury. 85% of the time, the primary cause are discs, hurting discs, painful discs. And that's what this surgery you're watching right now is used to treat. We treat painful discs with a laser. We debride the tear. Everything okay over there? Anyway, Henry, there are other causes of back pain. There are 30 to be exact. Why don't we share with our audience all 30 causes of back pain?
Of course.
I'm Dr. R. Deukmedjian with the Deuk Spine Institute, and we're going to discuss 30 causes of chronic back pain. Chronic back pain is back pain that lasts longer than 6 weeks, and there are 30 causes of chronic back pain. The most common cause is going to be a disc injury. Disc injuries such as disc herniations, disc bulges, disc ruptures, degenerative disc disease account for 86% of chronic debilitating back pain, and they are totally fixable with the proper treatment. The best treatment for disc injuries is Deuk laser disc repair. Let's take a look at the 5 lumbar discs that can be injured. The most common disc to be injured is L4-5, followed by L5-S1, then L3-4. The L1-2 and L2-3 discs are far less commonly affected. Next, we have facet joints. Facet joints are small joints located behind the discs in the back of the spine. There are 10 facet joints, each paired left and right, L1-2, L2-3, L3-4, L4-5, and L5-S1. The most common facet joints to cause chronic back pain are L4-5, followed by L5-S1, followed by L3-4, in that order. After the facet joints, which account for approximately 10% of chronic back pain, we move on to the sacroiliac joint. The sacroiliac joint accounts with the piriformis muscle for approximately 4% of chronic back pain. The sacroiliac joint is a joint located between the tailbone or sacrum and the iliac bone. There is a left and right sacroiliac joint. In this diagram, you can see the joints turning red, indicating inflammation and pain either in the left or right sacroiliac joint. These sacroiliac joint injuries and pain can be treated most effectively with the Deuk plasma rhizotomy of the SI joints offered at Deuk Spine or Deuk Joint Institute. The 4th most common cause of chronic back pain is a piriformis muscle injury. The piriformis muscle is located in the buttock, and there is a left and a right piriformis muscle. The muscle gets torn, unfortunately, when people bend the wrong way. This usually occurs in patients with orthopedic problems such as hip pain, knee pain, or back pain. By bending improperly, they put the muscle under too much stress and they tear the muscle. The torn piriformis muscle causes severe debilitating pain in the top of the buttock. There is a left and a right piriformis muscle, and this can be treated most effectively with the Deuk piriformis muscle release. This is performed percutaneously with a 4mm incision. The sciatic nerve does run through the piriformis muscle, and many patients with piriformis muscle syndrome also have sciatic pain down their legs, with pain, numbness, tingling, and weakness in the leg that's affected on the side of the piriformis muscle. Piriformis muscle can be treated with injections such as steroids, Botox, PRP, or stem cells. However, those injections always wear off and the patients end up coming back with the piriformis muscle pain that reoccurs. The most definitive treatment for permanent relief of piriformis syndrome is a piriformis muscle release. Next, injuries to the bones of the spine, such as the vertebral bodies, with trauma can cause fractures of the vertebral body. Vertebral body fracture is diagnosed with X-rays or CAT scan or MRI, and they're treated with injection of cement into the vertebral body. Looking at the vertebral bodies, the most common to be affected is L1, followed by L2, then L3, L4, and L5. The sacrum can also be fractured. Finally, the coccyx is the last cause of chronic back pain. You can see in the diagram the red coccyx at the bottom. This comes usually from an injury where the patient falls on their bottom, sustains pain at the tailbone, and this can be treated with injections of the coccyx ligament. These are the 30 most common causes of chronic debilitating back pain, the most common being the disc, causing 85% of chronic back pain, followed by the facet joint, causing 10% of the chronic back pain, followed by the piriformis muscle and sacroiliac joint, which cause 4% of chronic back pain, totaling 99% of chronic back pain, which is totally fixable and curable with the right treatment. Thank you. I'm Dr. Deukmedjian. Thanks for joining us.
That was perfect. Welcome back. You can see from our video there are 30 very specific sources to chronic back pain discovered here at Deuk Spine Institute, the 30 causes. And when we evaluate patients with chronic back pain, we actually look for those 30 causes and on every patient, because it turns out the average patient has 4 to 5. Somewhere between 4 and 5 of those causes causing their back pain. This patient has two. There's the inflammation right there. You can see it. And that's what we're here to do, is we're here to remove the source of pain in the disc. There are two discs that are hurting him, the L3-4 and L4-5, and that's what we're working on right now, the L4-5, right, Luis? All right, I understand there's a few questions from our audience.
Yes, this first question, both questions are coming from AAKK on YouTube.
All right, and AAKK is a surgeon, I understand.
I believe so. Asking, hi, Dr. Deuk, excellent view in the discogram. In
Thanks.
your practice, have you ever seen a severe spondylolisthesis of L3-4 and L4-5 cause foot drop combined with weakened plantar flexion?
Can L3-4 spondy cause foot drop? The answer is 100% yes. Because think about it. The nerves that go down to the tibialis anterior and extensor hallucis longus, basically your L4, L5 nerve roots, they must pass by the L3-4 disc and that segment, going down to the next segment where they exit the spinal canal and enter the foramen at L4-5 and L5-S1. So because they're passing L3-4 and there's a slippage, they can be entrapped. For sure. Yep. Nerves don't read the anatomy books. You just got to be smart enough of a doctor to figure out what's causing your patient's symptoms. And sometimes, you have to go beyond the book to use experience, knowledge to explain what you're finding. If I stuck to only textbooks, I would not have discovered this technology that I did. I would have just stuck to laminectomies, discectomies, infusions, and artificial discs, spinal cord stimulators, which now I know are unnecessary, dangerous procedures. All right, we're just about finished with the L4-5 disc. You can see we're inside the disc. The nerves are protected on the outside. There's a lot of scar tissue from chronic inflammation going on for many years in this patient's back. And he's been suffering, he's miserable. I was watching him in the recovery area, pre-op area, and he was just so uncomfortable because of back pain. So I think he's going to be happy with the results, I hope. Our average pain relief from the disc with the surgery is 99.6%. 99.6. It's basically 100%. All right, any other questions?
Yes, we have another question from AAKK asking, would the DLDR fix foot drop specifically from grade 3 spondylolisthesis, or would the patient just need a fusion?
Yeah, it's a great question. So if the patient has listhesis at 3-4 and they have no herniation, none at all, it's gone. The disc is 100% gone. All there is bone, and you are 100% positive that there's no disc material, then you don't need a fusion, you need a decompression, reconstruction, realignment, interbody cage, and a fusion. So you need decompression, realignment, stabilization with instrumented fusion. That's what I would do, but I have never seen that scenario in my career. I have always found that there is a herniation, usually in the lateral recess or the neural foramen, that is impinging on the nerves in addition to the listhesis. And if you just treat the herniation, you can actually cure the patient's symptoms completely by not even addressing the listhesis. I used to believe all listheses need to be fused. I was wrong. And that's what I used to do, was fusion for everybody with a listhesis. And there are a lot of surgeons who believe that listhesis equals fusion. You must do a decompression and fusion if they're symptomatic. But now that I have laser and I've been using it for years, I found the laser works better than any invasive surgery to eliminate patient symptoms permanently. That's been my experience. By the way, Henry just launched our Dancing Fusion Patient Video Playlist.
Yes,
For
sir.
those of you who are interested in the history of Deuk Spine Institute, we started by doing fusions many years ago, about 30 years ago. I started doing fusions. And when we opened our doors in 2014 for our surgery center, I did a lot of fusions back then. And the technique that I developed here at Deuk Spine was a minimally invasive, and it allowed the patients to go home within an hour or two of their fusion. And so to emphasize how well our patients did with fusion, we would do what's called a dancing fusion patient after surgery. So in the recovery room, before they left, they would come and do a dance. So Henry just created the playlist on our Deuk Spine channel of our dancing fusion patients from 10 years ago, 11 and 12 years ago, just so you can see that we do fusions, and we do them, I think, better than anyone else out there, as evidenced by our patients' results. I've also peer-reviewed and published with spinal fusions myself as a leader in spinal fusions in the world. You can find my article in PubMed. If you go to the National Library of Medicine in the United States, you can find the transforaminal lumbar interbody fusion with Smith-Peterson osteotomies and instrumented segmental fusion to treat back pain and leg symptoms. I published my results many years ago, and we were getting 85% elimination of back pain and 90% elimination of leg symptoms with my technique. But I was doing it different than other people because I was performing an osteotomy. I removed the abnormal facet joints. Every single patient that I was doing fusion on had bad arthritis in their facet joints. And those facet joints were stuck together. They wouldn't move. You couldn't reduce them. You couldn't get the cage in that well. So I would remove the facets completely, and I would decompress the nerves in the foramen so their leg symptoms always went away. And we would cure their back pain, basically. Well, why wasn't 100%? I think it was 100% at the levels we treated with fusion. However, patients can't really tell themselves. So when you ask them, how much of your back pain did I get rid of? And if they have pain coming from something else, like a piriformis, SI, other facets adjacent, then they would say, oh yeah, there's still some pain. But it wasn't pain where I did the surgery, it was pain adjacent to or next to. So it's really hard for most people to tell. All right. Any other questions?
Yes, we have a couple more questions. This next one is from Patricia on Facebook.
Hi, Patricia. Welcome.
Asking, can spondy L4, L5, and S1 cause knee pain, weakness in leg instability?
Absolutely. Yes, it can. It can definitely do all those things. But if you have pain in the joint itself, like if you sit down on a chair and you start like extending your knee, like moving your knee, moving your leg, lifting it up, and you have pain in the knee joint, that is not coming from your back. It's coming from your knee joint. So it's very likely you have two problems. You have the weakness, numbness that may be from the pinched nerves in your back, and you have the knee pain from arthritis in the knee. It's not uncommon to have both, or like a meniscus tear, because you're not walking properly, right? So the best thing to do is to have me examine you, and I'll tell you exactly what's wrong, and more importantly, how we fix it, minimally invasive. Remember, the treatments that we offer at Deuk Spine are patented, and they're only available here. They're not available anywhere else in the world because I discovered them. They're, I think, the least invasive treatments available, and the ones that work. By the way, we don't do treatments because they're minimally invasive. We do treatments because they work. and we try to do the ones that work that are minimally invasive. Look at that piece of herniation right there. You guys see this?
Yes, we do.
Right? That came out of his back. It's right here. That's a pretty good sized piece of herniation from the last level. Can you see it right there?
Yes. Yes, we can. Yep, perfect.
All right, let's get started. We're now moving on to, you may want to take that and send it. Any other questions?
Yes, we have a couple more questions. Next one is coming
Laser.
from AAKK once more on YouTube, asking if the disc has a large central herniation with grade 3 through 4 spondylolisthesis, the DLDR would fix the symptoms, and from my understanding, herniations exacerbate listhesis and keep patients in that anatomy.
Yeah, you're right. It's very interesting you said that. I think I mentioned that one time before, many years, like years ago. So I've had patients with listhesis and a herniation. Once you go in and remove the herniation, their listhesis goes away. It's very weird. Probably because of muscle spasms, or possibly that the herniation is somehow keeping the bones from realigning. It doesn't happen every time. I would say in my experience, it probably happens 25% of the time. 75% of the time, getting rid of the herniation doesn't really fix the listhesis. It's still there. As far as a grade 3-4, I mean, a grade 3-4 listhesis is, I mean, I've never seen a grade 4 in my career. And I've been doing this for 30, how many years now? Since 97? No, I've been doing even before 97. Really 96. So that's what? 30 years I've been doing. How many grade 4 listhesis I've seen? 0. So you're asking about a unicorn, unless you see them wherever you live more frequently than I do. But a grade 3 you see once every 10 years. It's very rare. So you're asking about a very unusual, rare condition, like grade 3-4 listhesis plus a central herniation. I mean, do you know somebody with that? Or are you just kind of trying to figure out what you could ask me that's very off the wall? Anyway, yeah, that's a very unusual problem. But that said, if the symptoms, I believe, were coming from the herniation, I would still do the endoscopic surgery to try to eliminate the patient's symptoms and make them feel good, have a normal life. But I understand if that grade 3-4 listhesis is real, then there's a chance that that is ultimately contributing to their symptoms. So you'd have to address it surgically with realignment, decompression, and stabilization. All right, look at that inflammatory piece of tissue there. You guys just saw it floated up.
Yes, we did.
Any other questions?
Yes, we have a question and a comment. This question is from Matthew on
Matthew.
YouTube,
Welcome, Matthew, to our live stream.
asking, can cervical facet pain not only cause pain in the neck, but also to the shoulder and the head, causing severe headaches predominantly on one side?
Yes, absolutely, Matthew. The way facet syndrome causes what's called referred pain down into your shoulder is through activation of nerve roots. Basically, the facet is so painful that you feel it radiate down the root. Either it causes muscle spasms with the muscles overlying the facets, which is very common. That's what usually causes the headaches, is the muscles tighten up over the facets that are painful. And then you have muscle spasms causing neck pain and headaches and referred pain even into the shoulders. Okay, that's the most likely mechanism, but it's very well established that facet pain radiates and refers down into the shoulders. I hope I answered Matthew's question. There's a piece of herniation that I just got out, nice big chunk. Okay, remember, these herniations, they don't come out easily. You have to work at it. You got to use a laser. That's why most surgeons that do discectomy, laminectomy, they fail to get all this stuff out. They have to use special instruments called curettes and rongeurs to scrape and cut the disc. So they have to go in there, and basically They are doing it without actually seeing the herniation like we are. Like you see the herniation right there? That is the herniation. I can visualize it directly through the endoscope, okay? And a lot of surgeons don't do endoscopic surgery, so they're just reaching in there, grabbing around, hoping to get stuff out blindly, okay? Blindly doing it. And that's one of the reasons our procedure is so much better, because we're not blindly grabbing around anywhere inside the body like they are. And we're also not cutting out bones and ligaments they need. 5 minutes, Dr. Berndes, 5 minutes. All right. Just about done here. Well, I wonder what that is. Luis, you think that may be just some liquid? May just be out of focus there. Hope it's not the lens system. It's around 11 o'clock. Any other questions or comments?
Yes, we have a comment coming from Jamie on YouTube
Jamie.
saying,
Hi, Jamie. Welcome to our live stream on YouTube.
I recently watched Spine Scam on YouTube, and
Oh,
wow,
good.
very interesting, and it's crazy how all that goes on.
Yeah, it is. It's something people need to be aware of, because you guys are out there taking the recommendations of doctors who are basically being paid to recommend invasive surgery for you that you really don't even need. And the part about like doctors recommending invasive surgery you don't need, right? That's kind of out there already. We're not the first to point it out, but it's important that people know that. But also the part about why they're doing it, like the financial motivation, it's important for people to know the truth, because you can't solve a problem until you understand the problem, what causes it. And look at all that. There's the inflammatory tissue. That is what's causing his back pain right there. You guys see the pink tissue? That is
Yes, we do.
perfect, perfect, perfect. That is exactly what we're here for. The more peripheral we get on the disc, the more we see it. That is the Deuk laser disc repair, the only surgery in the world that targets that inflammatory tissue. All right, that's how I created the surgery 20 years ago, 21 years ago now. And we've been doing this surgery for about 20 years. And the whole purpose of this is to get rid of that pink stuff and get rid of the herniation, get rid of the herniation right here that's stuck within the annular tear. Because it's not the herniation outside you guys all look at on the MRI. That herniation is not causing the back pain. It's the part that's stuck in the tear. And I'm the first in the world to discover that. Everyone else has been paying attention to the herniation outside the disc, the part that's in the epidural space or the neuroforamen where the nerve root is, saying, oh, we got to go get rid of that and get the pressure off the nerve root. But nobody ever thought about the herniation inside the annular tear, the part that never quite made it out. And that's really where back pain comes from, and neck pain. That's what I've been saying for 20 years. I've been teaching my fellow neurosurgeons at meetings, through publications, and yet they don't listen. They don't care. And that's why I created Spine Scam. Because if the surgeons and doctors aren't going to care about the truth, maybe the patients will care. And it gives you at least the opportunity to learn the truth from somebody who's been doing this for 30 years. And I'm going to give you an opportunity to learn the truth. And in the end, if you do something about it, great. Advocate for yourself. But if you're not going to do anything about it, that's fine. That's your choice. But my job is to educate people, teach them the truth. The rest is up to you, whether you want to do something with that knowledge or you just want to put your head in the sand and ignore it, like the other surgeons. All right, we are just about done. Another minute or two, and this is the outside of the disc right here. You guys are seeing the outer part of the tear right there. That's the last of the inflammatory tissue right here. This is the last of the pain generator for this disc. We have conquered it, and I hope he does well. I really do. I love my patients, and I want them all to have a great life and have a successful surgery and have no problems with their surgery. That's my goal. That's what I'm supposed to do as a doctor, and that's what I take pride in doing. I got the best team in the world working with me here at Deuk Spine. For those of you who don't know, we're a small company. We have one little building here in Florida. We're trying to grow. It's hard to grow these days, the economy being bad and insurance companies not wanting to pay for new technologies, even ones that work. It's always a fight. It's always a struggle, but we're still here. All right, we're going to keep fighting until we can't fight anymore. I'm fighting for you, the patients, to give you guys an opportunity to have the right treatment for you, the best treatment available in the world. The future of spine surgery here today at Deuk Spine Institute. Right, Dr. Berndes? 30 seconds left. If you have questions, feel free to ask.
We do have one more question that just popped up from AAKK, once more on YouTube.
Sure.
Saying, thank you for your expertise, Dr. Deuk. Could you please explain how the DLDR is far superior to the disc FX procedure, which only removes parts of herniation and uses an RF burn probe?
Well, I think the answer is results. The disc FX procedure doesn't have good results. In other words, patients are not cured every time after the procedure, whereas the Deuk laser disc repair, our patients have zero pain in their disc after we treat it with laser. Also, the disc FX procedure, I think, is done without direct visualization of the pathology, which is the abnormal tissue. With Deuk laser disc repair, we're using an endoscope to treat this. And more importantly, that radio frequency probe cannot get rid of bone spurs. The Deuk laser can get rid of bone spurs. Radio frequency can never remove bone spurs. Our laser can. The only way to remove bone spurs is laser, drill, rongeur, ultrasonic. Those are the 4 ways to get rid of bone spurs. And yeah, these people need it. So disc FX doesn't do that. All right, guys, gals, we're done. I'm going to zap just one more spot, 30 seconds, and we're finished. If you have questions, type them up. Happy to answer them for you. But we're pretty much done here. The next patient is a thoracic and cervical Deuk plasma rhizotomy. He comes to us from New York. I can't tell you much else about him without giving away identity, but he came to us a year and a half ago for thoracic facet pain. He was incapacitated with his pain. He couldn't do anything in life. He literally laid around in bed all day for weeks at a time when he had a flare-up. His doctors, he went to the best doctors in New York. All they could do was medial branch block and RFA, which stopped working and really didn't help him. He came to us, we cured his pain. He's now a new man, but he's got pain in other parts of his spine. So that's what we're going to be fixing next. You guys will not see that because it'll be in a different room. You have a guide wire. But we'll be back for one last surgery that's broadcast. It will be carpal tunnel release. We did the same patient 2 weeks ago, and he did great. And he's now coming back for a second surgery on the other hand, where we're going to go in and unpinch the nerve in the palm of his hand. Okay, he's got bad carpal tunnel syndrome. So you guys can watch that if you want. It's not really spine surgery, but as a neurosurgeon, we treat nerves, and that is one of the surgeries that I do. All right. Thanks for joining us. We're pretty much done here. Just doing our antibiotic injection, and we're finished. Henry, anything else?
No current questions.
Thanks, everyone. Great job. I'm here with one of my post-op patients. We get a lot of requests for Dr. Deuk. Can you show us a patient that had the surgery several weeks ago? Well, here's one. She had the Deuk laser disc repair done at L3-4, L4-5. You were having back and leg symptoms before surgery. How are you doing today?
I have no pain today. I have no pain today. I suffered for such a long time. The leg pain was there for a good close to 3 years. I got to where I could hardly do anything. I'm normally an Energizer bunny. I'm always busy doing something all day long. It terribly curtailed my life. I couldn't hardly do anything without being in pain. And for a long time, I had to push through some just to do normal things, just to get me ready for the day. Now, it's gone.
Amen.
It's gone.
Now, you had your surgery done here at Deuk Spine Institute in Florida in between two massive hurricanes, right?
Yes.
We had Milton recently, and before that we had Helene. And you had your surgeries smack in the middle of those two, between those two hurricanes.
Yes.
What brought you to Deuk Spine Institute?
Well, my husband always trying to find something to help me. He did his research, and online we found you. So we came to see what you offered and what could be done. The other doctors wanted to fuse my back and L5 all the way to my tailbone, and I didn't want that. I was afraid of that. I had done decompression surgery at L3-4-4-5. Within a few weeks after having that done, I was right back in the same pain.
We tell people about laminectomy. You had a laminectomy, it
Yes.
didn't work. I tell people avoid laminectomies. They're removing bones and ligaments out of the spine. It's very invasive, bloody, and damaging. But the laser surgery you had with us, we went in with a small, tiny Band-Aid incision.
Yes.
Outpatient. There was no bleeding.
And no pain from the surgery.
No pain from the surgery.
Wow.
Right?
I couldn't believe it. I'm like, you gave me a prescription for muscle relaxants, and I'm like, no pain surgery. I called to make sure. Are you sure? Because I don't have a drawer full of pain pills because I don't believe in them, but I know I need them for surgery. I needed them when I had my decompression surgery. I needed them when I had emergency cervical surgery, and I had no pain, no surgical pain.
Yes, our procedure is so
Wow.
gentle that there's no surgical pain and you don't need to take painkillers.
No.
Amazing. Well, thank you for sharing your story with us, and you've been through so much, and you're in my prayers. I hope you do very well. Enjoy life.
Thank you. I so appreciate the prayers.
You're welcome.